everyone, I'm Dr. Preeti Sharma, and in this session we are going to discuss the questions that were asked in this particular INI-CET November 22. Now before we begin, this was one of a kind of a session because this had two particular different papers that were involved, the morning and the evening session. Going by the general feedback that we got from the students, the morning session was slightly easier in comparison to the evening one. But yes, when I saw through the questions and when I discussed it with the students, I realized that more or less the questions and the topics remained the same. It was only a difference in the options that was given between the two sessions that were there. Also, another thing that I would want to tell the students is, like, by now you all already know the answers, you've discussed it with your friends, your colleagues and your teachers. So the purpose of this session is not only to tell you the answer of the question that came in the paper, but is also to tell you that going forward, what do you learn from this exam and how can you apply that in your upcoming exams, that is, be it the upcoming NEET or the FMGE. Now, one thing that all of us definitely learned from this was that the importance of previous year questions, or if I can say previous year topics, is not going to go anywhere. So even if it is INI-CET and everyone expects it to be on the tougher side, one thing that all of us noticed was that the importance of PYTs was very evident. Previous year topics were asked more. There were certain questions which were direct repeats also. So like I always say, focus on the previous year topics always, and after that, if time permits, you can do the other questions and other topics as well. So without any further delay, I think let us first begin with the recall of this. And yes, anything that you feel that was different, you can always comment and let us know, and we can always discuss that also later. So the first question was identification of instrument, and I think most of you did get it right that the instrument shown below was basically the Klima needle. Now, how do you identify these? So I've got you three pictures because the purpose of this session is not just alone knowing the answers, but also knowing that going forward, how are we going to get questions in the NEET and the FMGE exam. So first and foremost, in the exam, you're going to get two types of needles, as they say. So these are either going to be the bone marrow aspirate needles or these are going to be the bone marrow biopsy needles. So when we talk about BMA, the two types of needles are Salhas and Klima. And how do I identify them? See, look at these needles. If you notice very carefully, they have a screw. Now, the location of that screw is going to make all the difference. Means, for example, if I say that the screw is on the side, if I'm dealing with the side screw, then S for S. Please remember, a side screw is going to be the Salhas needle. Versus, look at the screw over here. The screw is basically longitudinal along the long axis. So, if I'm dealing with a longitudinal screw, then definitely we are talking about the Klima needle. So in the exam, let me get back to my question. In the exam, as I saw, I could notice that the screw was longitudinal one, and if I'm dealing with the longitudinal one, I had to answer the Klima needle only. Okay, what are the other options? So longitudinal screw was the Klima needle. Salhas is going to have a side screw. There's another needle called the Islam's needle, the picture of which you don't get, but yeah, that is another one that you should be knowing for BMA. Versus what about BMB? If I would have got a question for bone marrow biopsy, so for biopsy, you're going to identify that as the T-shaped needle. Means you can see the Jamshidi's needle. This is the one that was used in the olden times. Nowadays, we have only a single-use one, right? The single-use one is going to look like this. So basically, there's a handle. Why do I say T-shape? Because there's a handle out here which is actually going to help you hold it, grip properly. That is how the purpose of this particular needle. So, well, having said that, I think the first one was quite evident. This is the bone marrow aspirate Klima needle that they gave you. But yeah, these are the other three needles that you need to know for the exam. So this question seems to be sorted, right? Let's move on to the next question. Another very much expected question. In fact, we had also discussed it a couple of days ago. So first, we have an adult female who is diagnosed with a gastric tumor. And if you notice that this particular paper had a lot of questions on immunohistochemistry. So first and foremost, what was the IHC marker mentioned? They had mentioned CD117 positive. What was negative? Cytokeratin is said to be negative. S100 is said to be negative. So I didn't have to really focus on the negative aspect because what was given as positive was quite characteristic. And that was a case of, if you all remember, this is a case of GIST because CD117 is also referred to as INI-CET. That is something that you need to know. So first and foremost, there's a very famous mnemonic on how you're going to learn the CD117 mutations and positivity. So please remember, the mnemonic goes by that whenever you have to go and play any game, you always carry a kit bag with yourself, right? So whenever we have to go and play a game, a kit bag is something that you will be carrying. So that means that G is going to be for GIST. That's the first tumor that shows you c-KIT or CD117 mutation. Then with AM, you have a leukemia, that is AML. M alone, you have something called mastocytosis. Then with ME, you have melanoma. And finally, with SE, you are going to have seminoma. So I guess everyone knows that seminoma, if it occurs in the testes, then it also has an ovarian counterpart, and that ovarian counterpart is going to be dysgerminoma. So repeating guys, G for GIST, AM for AML, M alone for mastocytosis, ME for melanoma, and SE for seminoma. So next time you go to play any game like cricket or basketball, football, you know you're carrying a kit and you know that you've also learnt a mnemonic. So coming back, this was a classical case. Out of them, GIST was given in the question. So I classically marked GIST as my answer. But what would have been the case going forward for the other exams? Please remember, the first thing that I actually need to know in the paper, whenever you're picking up a question of IHC in the paper, go for your basics. Has the examiner given me a carcinoma or a sarcoma or a lymphoma or a melanoma? 4 things. So how are we going to identify that? Firstly, whenever the examiner is wanting to tell me any kind of carcinoma, any kind, be it adeno or squamous or transitional cell carcinoma, carcinomas are CK positive. So carcinoma CC. Carcinomas are cytokeratin positive. Similarly, if the examiner wants to tell me about some kind of a sarcoma, so sarcomas are going to be vimentin positive. So always remember this, we have carcinomas, C for C, that is cytokeratin positive, and sarcoma, which is vimentin positive. What about lymphoma, be it a Hodgkin's lymphoma or a non-Hodgkin's lymphoma? L for L. Lymphomas are LCA positive. LCA stands for what? LCA stands for leukocyte common antigen. LCA stands for leukocyte common antigen. So that basically means that LCA is also known as something else, which I hope all of you remember, CD45, right? So now, by now, I have realized that more or less I can identify them with their alphabets only. So when I'm talking about lymphoma, I think the L for L will stay in your mind. What am I left with? I'm left with a melanoma. I'm left with a melanoma, and melanoma is going to be HMB45 positive, giving you a recap. Carcinoma CK, lymphoma LCA, melanoma HMB45. So the only one without a mnemonic that I have to learn is sarcoma is vimentin positive. If you remember these 4 things for your exam, be it NEET or FMGE, I can guarantee that most of your questions are going to be sorted. And this paper had a total of 4 to 5 questions on immunohistochemistry, which I'm gradually going to discuss with you, telling us that going forward, IHC is definitely going to be a very important part of every exam. More so because in the world of pathology, IHC has become the mainstay of the diagnosis of a lot of lesions. So they are going more towards the modern trends and asking you a lot of questions on those. Okay, having said this question seems to be sorted. We can move on to the next question. Another pattern that this paper really saw in detail was match the following. So they've stopped giving you those one-liners. So instead of giving you a single one-liner and testing you on your fact-based questions, they decided that they'll give you multiple one-liners in a single question by giving you this format of match the following. So over here, I think the first one, I've not given you the final options, but I guess we can match it on our own. This was a pure cramming up kind of a question, so there's not much of logic that I can help you with. But yeah, I can help you with a couple of mnemonics out here. So I think c-KIT now becomes very, very simple. I know KIT games, so I think one thing that I can match it to is definitely going to be GIST. Moving on to the next, we have B2. If you guys remembered what is the other name of B2, the story would have been very, very easy. See, I'll tell you something. There are multiple names of this. There is something called B1, B2. Some authors also call this as EGFR1 or EGFR2. And this 2 is also known as HER2 new. So put all the ones together and the twos together. So B1 is EGFR1, B2 is EGFR2, which is HER2 new. Which cancers are they mutated in? Please remember the 111s, I have to keep the first alphabet, that is A. And in all the 221s, I have to keep the second alphabet, that is B. Means what? The first one is mutated in adenocarcinoma lung. The first one is mutated in adenocarcinoma lung, and the second one, I think there's no mnemonic only needed. HER2 new means I'm dealing with breast cancer, right? So the option number 2 was matched with breast cancer. Moving on to the last one actually first, PDGFR beta. PDGF, it's a growth factor, GF growth factor. So PDGFR beta, remember beta will always stand for some kind of a brain tumor. And which is the brain tumor that was given out here? The brain tumor out here was astrocytoma. So this option is also sorted. Remember PDGFR beta, beta brain. What am I left with? By ruling out also, KRAS goes for adenocarcinoma lungs, but I want to tell you a little bit about RAS going for your further exams. So there are 3 types of RAS that you have to know for your paper, and there's, there are 3 alphabets, KRAS, HRAS and NRAS, but there's a problem that when we go into the exam, we always tend to, forget these alphabets. You'll come up with a new RAS because under that stress and anxiety, pretty much everything is possible, right? You might end up making an LRAS or something different. So remember, whenever you're talking about RAS, it's something like asking the way. When you ask the way, if you have to go somewhere and you ask someone how should I go there, you say Rasta kahan hai? You always say Rasta kahan hai? So now tell me guys, for RAS, what are the 3 alphabets that you're gonna learn? The 3 alphabets are K, H and N. So that is what I've written. There are 3 RAS molecules. So now you need to know, their alphabets. Now you need to basically know that what is going to be their, the mutations, which cancers will they cause. So remember KRAS, K for couple. What are the couple tumors? K for colon cancer, pancreatic cancer and lung cancer. That is what was given in the question to you, adenocarcinoma lung. So KPL, colon, pancreas and lungs. For HRAS, I'm going to make a little bit of a diagram over here because with this H, I'm going to make 2 kidneys. So it is primarily mutated in renal cell carcinoma, and below the kidney we have the bladder, right? So urinary bladder cancer, RCC and urinary bladder cancer. And NRAS is everything to do with M, while N and M same neighbors, right? N and M saath aate hain. So N is going to be mutated in AML and melanoma. So simple, when I'm talking about KRAS, it is KPL. HRAS is going to be the H, that is I make a kidney and bladder out of it, and NRAS is going to be all the M's that I have, right? Now, obviously this session is something which you already know these answers, you've read your course, so why not I ask you something so that you can also be equally involved in this session. So you guys, especially the ones who are now preparing for the next INI-CET, you need to tell me that out of these K, H and N, which is the one that is involved in pituitary cancers, pituitary carcinoma. That is the question now that you need to know for the next INI or the NEET exam. Not per se important for FMG, but very important for NEET and INI. And let me know in the comments below. Obviously, I'll be putting up the right answer also. Okay, moving forward. So I think this question seems to be sorted. Your match the followings are done. Everyone seems to be comfortable with it. So with KRAS over here, I had then couple. Couple means lungs. So I've put it up over here. Always remember these 3 RAS, KPL, very, very important. Couple and KHN, the 3 alphabets are important. Okay, moving on to the next question. Another much expected question. Nothing which came as a shocker out here. They asked you which of the following is not associated with a poor prognosis of BALL. So first and foremost, you need to know the prognostic factors of ALL, right? Okay, so they ask you which is not. So these, most of them are associated with a poor prognosis. You had to tell me which of them is not associated. So I'll come back to this question. Let me quickly make you a table for what are the prognostic factors of ALL. So first and foremost, please remember that when it comes to the age, so which are the prognostic factors which are good? Till the time they give you a 2 to 10-year-old female, that is said to be good. Means anything other than that, a less than 1-year-old or a more than 10-year-old boy is going to have a bad prognosis. So first, learn any one. My advice to you is in this table, learn any one, and I'll give you a little bit of logic also. Remember, when I talk about FAB, there are two classifications. I think everyone remembers from ALL that there are two classifications, right? One classification has been given by the very famous World Health Organization, and the other classification is basically French, American, and British. So many people and many authors came together. French, American, British classification. Okay, as per the FAB classification, ALL is L1, L2, L3. These are the classification, and WHO says that ALL is BALL and TALL. So now you need to know that which are the good and the bad ones. So remember, L1 is the good one and L3 is the bad one. So where is L2? Hanging in between. L2 is intermediate, right? So L1, which is the most common, is also said to be good for the patient. L3, which is the least common, is said to be bad for the patient. So God has decided whatever is most common, thankfully, is good. So even if it's common, patient will get cured from it, right? So good and common comes together. Versus WHO said, no, we don't want L1, L2, L3, we want B versus TALL. So remember, the BALL is said to be good and TALL is said to be bad. Is there any logic behind it? Yes. Remember, T for TALL is the one that can go into the tissues, that can show you tissue infiltration. So now imagine, let me give you examples of tissues. Imagine this goes into the brain, this goes into the mediastinum, or this goes into the testes. Now you'll say that, ma'am, something that has gone into the brain is definitely not going to be good, right? So now you understand that obviously because T for T, this is going into the tissues, that is why it's coming under a bad prognostic factor. Also at the same time, they will say that what all tissues? So brain, mediastinum and testes. Do you see there is testicular involvement? So automatically that's very bad. So with gender becomes bad. Now you get the concept behind it, that why did I say males have a poor prognosis? Because testicular involvement is occurring there, right? Okay, having said that, now coming to genetics, and that is the real deal. That is where students tend to falter a little. That, ma'am, which genetics are good and which genetics are bad? And I'll give you one very basic mnemonic for it. See, I say ALL, it has 3 alphabets. So anything that is to do with the number 3 is going to be good. So I'll ask you, if I say I'm dealing with some kind of a trisomy, you'll say trisomy 4, trisomy 7, trisomy 10. So you'll say, ma'am, trisomy means 3 chromosomes. Anything 3 is going to be good. Trisomy which chromosome? 4. 4 plus 3, 7. 7 plus 3, 10. So you will gradually realize that everything around here, I'm working it around 3 only, right? So all the try, all the 3 things are good. If I ask you, what about translocation 1, 2, 2, 1? You'll say, okay, 1 plus 2 is 3, 2 plus 1 is also 3. So this is also going to be good. If I ask you, how is hyperdiploidy? If I ask you, how is hyperdiploidy? You'll say diploid is 2, diploid die 2. Hyper means more than 2. More than 2 is obviously 3, right? So again, this comes under the good. So I realize everything 3 is going to be good. And other than 3, if I say now hypodiploidy, you'll say that is not coming out to be a 3. Translocation 922, that is not coming out to be 3. Translocation 411, nothing to do with 3. So anything that is not to do with 3 comes under the bad condition. Keeping all of this in mind, now let's go back to my question and try an attempt. Don't read the question, because this is where you get maximally confused in the paper. You forget to read true, false, except, not and all of those, right? Whenever you feel your mind has just frozen out there, start doing a true and false with the options. So tell me, hyperdiploidy, is it good or bad? Hyper, you'll say, ma'am, anything to do with 3 was good. Translocation 922 is not at all good. 411, nothing to do with 3, not at all good. And very, very young child is also going to be bad. Remember, less than 1 year old and boy, testicular involvement was bad. So now they said, which of the following is not associated with poor prognosis? The only one that is not associated with poor prognosis here is hyperdiploidy. So remember, this was, as I said in the beginning, this was not at all a shocker. This was a question that is much expected in all the exam formats from INI to NEET to FMGE. Okay, having said that, let's move on to the next question. Another quite a spotter, be it calling it from path or from dermatology, it's something that you have to know, and that is molluscum contagiosum. First and foremost, the answer to this question was very characteristic. It shows you the HP bodies, but how else is the question going to come? Remember, molluscum contagiosum is caused by a virus called molluscum contagiosum virus, which belongs to the pox virus family. It belongs to the pox virus family, which is the largest DNA family. The largest virus, if you remember, it belongs to the DNA viruses and it's the largest, right? And do you remember how does a pox virus look like? I know I'm asking you a little bit of micro out here, but it's a very important question for your exam. How does a pox virus look like? So I've learned pox is like a box. Every pox virus is like a box. So it's going to look like a box like this. You can call it a box or you can call it a brick. Right? And the box is very heavy. Why? See, I've called it size wise also, I'm calling it largest and I'm saying it's very heavy. Why is it heavy? Something will be heavy if you put a dumbbell inside it. You put a dumbbell inside it, it's going to be very heavy. So, you know, it is having a dumbbell shaped DNA core. It is going to have a dumbbell shaped DNA core. So, going by that concept, please remember, pox is a box and it's a heavy box. Why is it a heavy box? Because it's going to have a dumbbell inside it. And because of that, it's become the largest virus. So that is molluscum contagiosum virus. Now, how does the patient present? Let me show you. Patient presents like this. This is a very classical dermatology image. You will see, look at the color of these papules. These are tan color, almost the color of the skin, a little darker. And if I zoom in and show you, you will see that there is definitely something which is as a depression in the center. Over here, over here, over here. So what is this? This is umbilication. This condition or this situation is known as umbilication, which basically means that there's a depression. There's some depression in the center. What if I press it? Now, what am I going to do? I'm going to press it over here. When I'll press it with my fingers, some material is going to come out. Some material will come out and that material is going to show me which bodies? The famous Henderson-Patterson bodies. The HP bodies are going to be seen. Now guys, first and foremost, have a look at these round structures. These are all the Henderson-Patterson bodies that we have. Let me show you what they gave you in the paper. Now look at this image that they gave you in the paper. What did you see over here? You will say, ma'am, over here, I see there is this kind of a lesion. This is a biopsy histopathology picture. And this is going to show me a cup-shaped lesion. So, okay. So, when I say cup-shaped, cup is always going to be open, right? There's going to be one open center. So, this much of area is open. Why is it open? Is this corresponding to the clinical image? Can I say that this depression in the center, which umbilication through which material was coming out, it's the same thing over here. So, this is nothing but the umbilication that I'm talking about, right? And now, if you look carefully, you can see all those pink color bodies everywhere. Those are all referred to as the HP bodies, Henderson-Patterson bodies. And going forward for the NEET and the INI exams, I would definitely tell you to learn that is there any special stain for the Henderson-Patterson bodies, and that's a table that I want you to make because it's definitely going to help you in every exam format going forward also. And what is that table? You need to know the special stain and other uses of that special stain. So first and foremost, there is something known as the floxine tartarate stain. There is something known as floxine tartarate stain. So they will ask you that what all are the uses of this. So P and P. Remember, floxine tartarate stain is used for which bodies? It is used for P bodies, that is HP bodies. And number 2, for which cells in the GIT are they useful for? They are useful for the Paneth cells in the GIT. So this is not for the FMG. I would tell the FMG students not to learn all the uses of this floxine tartarate. But yeah, only for HP bodies you have to know. HP bodies are going to be floxine tartarate. For the NEET students, please remember one more use of this stain, and that is the Paneth cells of the GIT. Having said that, the question again doesn't get over here because there are two types of HP bodies which you read in micro and you commonly get confused. So the kind of HP bodies that I'm talking about in molluscum contagiosum is going to be the Henderson-Patterson bodies. HP over here is Henderson-Patterson. There is another body that you call as HP, which is the Halbersteder-Prowaski bodies, which you see in a case of trachoma. In a case of trachoma, you see the Halbersteder-Prowaski bodies, and trachoma means eye involvement. So, common sense. You will say, ma'am, molluscum contagiosum is a dermat condition, so I'll see it in the skin, obviously. Trachoma is related to the eye. So, where am I going to see the Halbersteder-Prowaski bodies? In the eye, obviously. So, you see it basically in the conjunctival scrapings. You are not going to get a picture of it. Honestly telling you, you won't get a picture of it. But yeah, you should know that, okay, the Halbersteder-Prowaski bodies that are seen in trachoma, they are going to be seen in the eyes. So, the sample that I'll be needing are the conjunctival scrapings. I know these are the kind of things we very casually overlook through because we are not always in the mood of integrating. But honestly letting you know that in the exam, when you go and you pick up these kind of questions, you're going to realize that you're going to getting confused between the different kind of HP bodies. So this will actually help you. The story of this question is not over. The purpose of this recall session is not only to tell you the answer, it is also to tell you that how you're supposed to practice PYQs. This is one of the easiest questions. I could have finished it off within a second, right? But the point is that I should be able to tell you how to solve questions when you're doing it on your own. So you also look at the other options, because the next exam could be just another question, the same options, but one twist in the story. So where are we going to see Aschoff bodies? I think everyone knows that is seen in rheumatic heart disease. Where do we see Torrey's bodies? So Torrey's bodies are going to be seen in yellow fever. See, that's the RRL. The Torrey's bodies are going to be seen in yellow fever. And where do we do a Zank smear? This is done for herpes. Giant cells are basically seen with herpes. So that was the other one. But here we were asked, obviously, molluscum. So the answer was Henderson-Patterson. I hope the question all in all is sorted for everyone, and we can move on to the next question. One of the not so expected questions for INI-CET. Definitely expected in other exams, but not in INI-CET because it's way too simple. But we were not complaining, were we? So some of the students said that in one of the sessions it came as a spotter. In the other session, some students said that there was a CNS or a neurological deficit that was mentioned in the patient. Neurological deficit or CNS problem that was mentioned in the patient. So then again, a lot of students said that the picture is quite characteristic. What is the picture showing you? This is a case of Gaucher's disease. Why, guys? What does Gaucher's disease show you? Gaucher's disease shows you the crumpled tissue paper appearance. Look at this picture. Look at this big cell. Let me tell you, this big cell is a macrophage. And if you zoom into this macrophage, can you see those white lines? You know, as if many a times in anger, when you crumple your, obviously you don't crumple your notes, but you crumple a paper, does it get those lines, right? Right, the wrinkled lines, same way, crumpled tissue paper appearance is seen in Gaucher's. I think everyone knows G for G. Glucocerebrosidase deficiency, beta glucocerebrosidase deficiency is something that is noted for Gaucher's, right? Okay, so having said that, now G for G I will remember, crumpled tissue paper also I will remember, but what about that neurological deficit? So I think everyone knows Gaucher's disease is of two types, type 1 and type 2. So this CNS abnormality or neurological problem, Robbins has very clearly mentioned that type 2 Gaucher's can show you neurological or CNS abnormalities. Okay, well, having said that, let's move forward. Let's go on to what are the other things written. I see one more option called as Tay-Sachs disease. So are there other pictures in the exam that I can get going forward? Yes, there are very important two black and white photos. Everyone knows black and white photos mean electron microscopy. In pathology, that is what it means, right? So if you look at this picture, this is everyone's favorite. This is the classical onion skinning kind of a pattern that I'm going to see over here. And please remember, this onion skinning is very characteristically seen in Tay-Sachs disease. I'm not saying it's specific. Let me tell you one more thing. None of these findings are specific. Neither is zebra body specific nor is onion skinning. I'm just telling you what is the best answer that you're going to select. So Tay-Sachs disease, everyone knows it's a lysosomal storage disorder, right? So when I say lysosomal storage disorder, The onion skinning, if they ask you, has occurred of which organelle, it is going to be of the lysosomes only. Actually, can you imagine, such a common sense question has come. They have asked you that, okay, Tay-Sachs disease shows you this onion skinning, but it is the onion skinning of which organelle, mitochondria or ribosome or lysosome. And students were in a state of, were a little in dilemma that, we've only read onion skinning, but onion skinning of what? Because common sense doesn't come very commonly in the exam, does it? But yes, if you would have just thought logically that it's a lysosomal storage disorder, then onion skinning obviously is going to happen in the lysosomes only, right? And I hope everyone also remembers what is the enzyme deficiency of Tay-Sachs disease. It is hexosaminidase deficiency. It is hexosaminidase deficiency. Versus I see another black and white picture on the side. I can see the name is quite explanatory, right? Naam se pata lag raha hai that they are black and white stripes. So black and white stripe means what? Zebra bodies. These are seen in a couple of conditions. They can be seen in Niemann-Pick disease. They can be seen also in Fabry's for that matter. So yes, as I said, these are again lysosomal storage disorders, but as I said, these are not specific for anything. Here they asked you the crumpled tissue paper appearance for Gaucher's, that was characteristic. Okay, having said that, let's move on to the next question. Again, do I call this a tough topic or do I call this a topic which was not expected? Not at all. It was much expected. It has always been an expected question in every exam format. So here you have a 24-year-old patient with history of a neck swelling on the right side of the thyroid with moves with deglutition. See, I know that thyroid swellings are the one that tend to move with deglutition. So here they've mentioned thyroid, but in most of the cases, they only write it neck swelling. So neck swelling can be what all? Neck swelling can be a lymph node. Neck swelling can be thyroid. Neck swelling can be a thyroglossal cyst also. So how will the examiner try to tell me that the neck swelling is from the thyroid when he says that the swelling is moving with deglutition? That is what you also do when a patient comes to you with a swelling in the anterior part of the neck. What do? You tell the patient to as if to swallow water or to swallow his saliva so that the swelling can move up and down. So same way, the purpose of that is because the swelling that is moving up and down is going to tell me that, yeah, it's the thyroid. Over here, they've also told you a thing called muscle invasion. Now, muscle invasion is something that I can see with any kind of cancer. So, muscle invasion was not the primary concern. The primary topic over here was this image that was given, the biopsy. Now, you will say that, ma'am, answer we've already got to know from our friends and teachers that it's papillary carcinoma, but what are the main features of papillary that usually the examiner gives you? He gives you things like orphan Annie and all of that, and that was really not mentioned over here. So, ab yahan par how was I supposed to get the question? You had to look at these. See, look at these structures. They are looking much like the papilla. They are looking long, extensions like the papilla. So that is why I called it papillary carcinoma. Firstly, why didn't I call it anything else? Even if you wanted to rule out Riedl's thyroiditis. Riedl's thyroiditis, as I say, it's something that results in a lot of fibrosis. When I say it results in a lot of fibrosis, that is very obvious that this particular inflammatory condition is going to be very hard. But it's not going to show me these kind of papillae, so ruled out. Hürthle cell tumor is ruled out. Why? Because again, no papillae seen, and Hürthle cells are what? Hürthle cells are the cells which are going to show me a lot of mitochondria. So something related to mitochondria has to be mentioned in the paper, which was not. Okay, follicular carcinoma. Let me give you one catch point that whenever in the exam they want to tell you about follicular carcinoma, they are going to tell you two types of invasions without which follicular carcinoma thyroid cannot be diagnosed. One of them is going to be the capsular invasion and the other one is going to be the vascular invasion. Capsular invasion and vascular invasion, and if these two invasions are not mentioned, don't mark follicular carcinoma. So this was quite a characteristic case of papillary carcinoma, and let us quickly revise all the features of papillary carcinoma thyroid. So first and foremost, as I said, you're going to see these long papillae that you have to know. So this is, if you notice very carefully, these are said to be true papillae, right? Why do I call them true papillae? Because please remember that, see, if you see over here, they are said to be true papillae, right? So if I draw these papillae, I will realize that they have a blood vessel going inside them. They have a vascular core. That is, they've got a backbone, they've got a core. If they've got a core, that means that they are true. Please remember. So true papilla are what are seen in papillary carcinoma thyroid. So why am I so obsessed with this true papilla story that I have? What is the situation of this true papilla? Because somewhere I must be seeing pseudo papilla also. Pseudo papilla, you'll see, ma'am, little bit of projections have happened. That will happen in Graves' disease. That can happen in Graves' disease. So papillary carcinoma thyroid are going to show me true papilla. And Graves, do you remember Graves' hyperthyroidism? The thyroid is working overtime, hyperactivity. So some papilla can form, but they'll be pseudo. Will they have the core? No, they will not have that core. So when that core is present, only then I call it a true papilla. Okay, that was first thing. The second one is very characteristic. You guys know that very famous finding that you have, and that is the orphan Annie eye nucleus, right? So firstly, orphan Annie was actually a cartoon, and you know, this is a very interesting story. If you read, the cartoon character forgot to draw the eyes. If you look at the eyes of this cartoon character, the eyes of her pet, they don't have eyeballs. They are empty eyes. So that is what they realized in papillary carcinoma. Look at the nuclei. The nuclei are totally empty. They are either, you can call them orphan Annie eye nucleus, or there are many authors calling them optically clear nucleus, which basically means that they are white. They are going to be white. So one question definitely comes to my mind, that why are they white? And the reason for that is, it is not actually white. It is not how it is in the body. This is something that I have created. Why? Because this is said to be a formalin artifact. This is said to be a formalin artifact. Means that, now think logically. When do you put something in formalin? Do you put your FNAC sample in formalin? No. FNAC, there is no formalin, ma'am, that is used. Okay. Do you put your biopsy sample in formalin? Yes. Biopsy samples are always sent in. Surgery samples are always sent in formalin. So tell me, where will you see orphan Annie eye? Will you see it on FNAC or on biopsy? Obviously, if I've used formalin, I will see the orphan Annie nucleus. If I've not used formalin, I will not see the orphan Annie nucleus. And this is something that you have to know. In FNAC, you don't see this finding. You only see this when you're talking about a biopsy, because only on a biopsy you're using formalin. Okay, what is next? Other than this, in the nucleus, I also see, look at this nucleus. I see that in the nucleus, there is a pink color dot. So inclusion, basically, I call it INCI, inky. Why? Intranuclear. Yes, I can see that it is in the nucleus. Inclusion, perfect. But why did I call it cytoplasmic inclusion? Because you will ask me that what is this inclusion made up of? This inclusion is nothing but the cytoplasm from the cell which is moving inside. Basically, a little bit of the cytoplasm wanted to go and sit inside the nucleus. So the cytoplasm decided that I'm going to go and sit inside the nucleus. So the composition of that inclusion is nothing but cytoplasmic. So I call it intranuclear cytoplasmic inclusion. Okay, having said that, what else can I see? So I can see another INCI over here. Can you notice? You can see the INCI, another inclusion. But other than that, look at this nucleus. This is the nucleus which is showing me the classical coffee bean appearance, right? So yes, coffee bean appearance is seen over here. Well, now I realize that most of the things over here, either the nuclei are going to look totally white. Totally white means I'm talking about orphan Annie nucleus. Or the nucleus is going to show me an inclusion, that is INCI. Or the nucleus is going to show me a groove, and that is going to be coffee bean appearance. So basically, the point is that papillary carcinoma thyroid is going to be identified by the nuclear features, right? Coming on to the next one. I think everyone's favorite. Every papillary tumor, now note, not just papillary carcinoma thyroid, but any papillary tumor in the body, be it papillary renal cell carcinoma, papillary lung cancer, papillary, colon, endometrium, any papillary cancer is going to show me psammoma bodies. So yes, I can see that calcium related psammoma body over here, which is very, very evident. And I think that famous onion skinning appearance, lamellated appearance, you all know. Now let me tell you everything that I showed you right now, starting from papillae, orphan Annie, inky, the psammoma bodies, the grooves, all of these were seen on biopsy. They can be seen on FNAC also, but there is something which is only seen on FNAC. only seen on FNSE, not on biopsy, and that is going to be the very famous chewing gum colloid. That is going to be the chewing gum colloid. So how do I learn this? Please remember, look at the picture first. See, chewing gum basically means that something that can be stretched out. Can you see this pink material is being stretched out over here? This is the chewing gum colloid. And why is it seen only on FNSE? Why not on biopsy? Because see, in the thyroid, what are you doing in FNSE? FNSE is what? A needle. You're putting a thin needle. So that needle, that colloid will get stuck into it. All the colloid is going to get stuck into this needle. So when you try to take it out, it stretches like a chewing gum. It's going to stretch out. So take home message is that all these findings are seen everywhere. All these findings are going to be seen everywhere. But I realize that orphan Annie eye nucleus is something that is only seen on a biopsy. It is a biopsy favorite. And the chewing gum colloid is going to be an FNSE favorite. These are not seen otherwise. So chewing gum colloid only on FNSE, orphan Annie only on biopsy. Well, that wraps up your entire image review of PCT, papillary carcinoma thyroid, one of the most important. And since we've spoken everything about it, I think you know what is the mutation in papillary carcinoma thyroid. It is the BRAF V600E mutation that you have to know. Okay, moving on to the next question. I've already told you papillary is the answer here, and for follicular I've told you would have had to have 2 invasions, so you should have been on a watch out. Which 2 invasions? Muscle was mentioned. See, this was mentioned over here to confuse you, but this is not the invasion you look out for in follicular. Here you look out for capsular and vascular invasion. That's the deal that you should be seeing. So I think this question is complete as a whole. Now let's move on to 2 questions. Let's make you attempt them first. I have an adult with dyspnea, shortness of breath and weight loss. Presence of a lung mass is there in the left main bronchus and biopsy of lung cancer. See, they've been nice. They've told you it's a cancer. They've given you a picture for it. They've also told you that there is positivity for P40. So that means there was an IHC related question that was mentioned. What is your diagnosis? So the answer to this question was squamous cell carcinoma lung. How did I identify? Because I could see a cancer with pink material. Pink material is nothing but keratin pearls. All that pink material was keratin pearls. So remember, whenever I'm talking about in lungs, I'm talking about that pearls wala tumor, that is squamous cell carcinoma, and pearls wala tumor will be positive for the P markers, P63 positive, P40 positive, out of which P40 is said to be the best marker for it. So remember, the pearls tumor is going to be positive for the PP markers, that is P63, P40. P40 is the best, and that is what was mentioned over here. So classically squamous cell. There was one more question on the same lung pathology and the same immunohistochemistry. So again, you had a chronic smoker. Again, there was breathlessness, chest pain, and a lung mass was seen. So lung mass, they're trying to indicate towards a cancer, but this time it was positive for chromogranin, another marker given. Chromogranin is something that is seen in small cell cancer. If you guys remember the, just few days before, 2-3 days before the exam, we had a quick discussion of few questions important. If you remember, I had taught you the entire profile of this small cell cancer. I had told you about chromogranin. I had told you that any neuroendocrine cancer, and I had warned you about it. We had even done the CK720 profile. I had warned you that, okay, IHC is going to be the mainstay in this paper, and thankfully the jinx worked and we got 5 questions on IHC itself. So telling you for the future also, it is going to be important. Now, what I'm going to do, so since I know that we have lung cancers coming a lot, let us quickly make a table of what are the important immunohistochemistries that I have to know in lung cancer. For those who are totally new to the concept, you feel you've never heard of what is happening out here. This is immunohistochemistry. It is a kind of a special stain. When I say it's a special stain, you'll always get some color. So remember, always the color that I'm going to get is going to be brown. There's always going to be. So IHC always gives a brown color. So now tell me, what are the different lesions or what are the markers that you have? So I just studied for squamous cell carcinoma, we show keratin pearls, right? So all the pearls related things were PP positive, P63 positive, P40 positive, and this was your question, P40 is the best. Okay, for large cell carcinoma, there's not much that you have to know. I'm left with adeno and small. Adeno starts with an A, so all the AA things, and A is the first alphabet. So all the 1 things are gonna come up. Means I'm talking about A for if someone says napsin A, and all the 1 things, that is muc 1 and TTF 1. So as I said, easiest way to learn is that all the adenocarcinoma is all the AA and the 1 things that I have. Versus squamous cell carcinoma, pearls are going to be all the PP things that I have. Okay, now coming to the largest list. See, I have always called small cell carcinoma. It sounds small, but it's damn deadly. It's going to have the lengthiest list. So remember, small cell carcinoma belongs to a neuroendocrine variety. And that is exactly what I had taught you before the INI-CET exam. That is, neuroendocrine tumors are going to be positive for a total of 6 markers. And you might right now feel that what a lengthy list. But let me tell you, this is really going to help you because every neuroendocrine tumor in the body will show you the same 6 markers again and again. So you just have to learn it once and then copy paste it everywhere. So remember, first we have 3 INs. What are the 3 INs? So we have synaptophysin, number 1. Then we have another cousin brother IN, that is chromogranin. So we have another cousin brother over here, and that is bombicin. Synaptophysin, chromogranin and bombicin, first 3 markers. And then we have 3 short forms, NSC, CD56 and CD57. So 3 INs and 3 short forms. That is how we learn it. That is important for INI and NEET aspirants. For FMG students, synaptophysin, chromogranin and NSC. These are the 3 that you have to know. Synapto, chromo and NSC, that is more than enough. So what were the 2 questions from the same table? First question was P40 positive. So if P40 is positive, you know they gave you a question on SCC, squamous cell carcinoma. And second was related to chromogranin positive. Chromogranin positivity clearly tells me that I am dealing with a case of small cell carcinoma. So 2 questions were sorted as it is. I hope you'll remember this. It's very, very important for the exam. At the same time, let's quickly look at all their pictures also. When I talk about any kind of squamous cell carcinoma, I think I've already told you the method of identification. That is the keratin pearls. Yes. How does adenocarcinoma look like? So be it adenocarcinoma of any place in the body. The word adeno means glands. So I'm gonna see round glands which I can see everywhere, right? Everywhere. And over here, this is not just adenocarcinoma of anywhere. I'm very certain that this is the adenocarcinoma of lung. And how am I so confident? Because on the corner, one corner over here, do you see some black pigment? So black pigment can only be seen in the lungs thanks to this person being either a smoker or this person probably living in a state where the AQI is really pathetic. So yes, someone who's either a smoker or someone who's living in this air pollution is going to have a lot of black color carbon in his lungs, right? So having said that, yes, this black color pigment tells me that, okay, there is something to do with lungs that is there, and the glands that are seen over here, they are going to tell me that, okay, this is a case of adenocarcinoma. Okay. Do you also see that there is a separate picture that I have pasted over here which is to do with brown color? So why is it to do with brown color? Because did I just tell you that what is the brown color stain that we are going to study? Immunohistochemistry. So remember, adenocarcinoma, what was the immunohistochemistry for adenocarcinoma? All the AA markers, 1 markers, so they're all going to give you a brown color. Coming to the small cell carcinoma is going to show you 2 features. Number 1 is salt and pepper chromatin. What do you mean by salt and pepper? See, obviously, if this is a cell and if this is a nucleus, usually you expect that the nucleus should be totally blue. But suddenly, in this situation, you will realize that the nucleus is going to be blue and white, basically salt and pepper. Salt and pepper. So let us zoom into this picture. Can you appreciate the nucleus here, or any nucleus you want to pick up of your choice? You will say, ma'am, they're not exactly blue. I can see those white dots in them. That is the very famous salt and pepper chromatin that you have to know. And that is again something which is going to be seen in all the neuroendocrine tumors, right? But one more thing small cell cancer shows you, and that is the very, very famous Azzopardi effect. So what do I mean by Azzopardi effect? In simple words, Azzopardi effect is a blue blood vessel. Azopardi effect is a blue blood vessel. And what do I mean by that blue blood vessel? Look at this. Blood vessel is supposed to look blood, na? So blood vessel is supposed to look pink and red and all of that. Here I'm seeing a blood vessel which is blue. So why? Two questions. Why is it looking blue? It's looking blue because all these cancer cells are smudging. Cancer cells are very weak, okay? Cancer cells are going to break over here. So this is basically the smudging, like ink smudge hota hai, right? So this is something like the smudging of the cancer cells that you're gonna see. So all this blue color is what? Nothing but the cancer cell. It is the cancer cell DNA. But then you say that, ma'am, now I know quite a lot of pathology by now. Blue color is almost everything in path. Everything is pink and blue. So now you can't fool us by just saying that this is DNA. You'll have to prove it, right? So if you ask me for a proof, what am I going to do? I'm going to put a stain for DNA and prove it to you. Okay, so now what is the special stain for DNA that you have? That is something known as Fulgen stain. How will I learn this? Because path has a lot of stains already. So why am I adding one more to your burden? So remember gen. DNA goes in your generations, right? DNA goes in your generations. So DNA is Fulgen stain positive. That is a pure cramming up, mugging up question, but you'll have to do that. So yes, if you say that, ma'am, everything looks pink and blue, can you prove that this is DNA only? So I'll say, okay, I'll put the Fulgen stain. It will come out to be positive and you'll get to know that this is DNA. And what is this blue blood vessel known as? This effect is referred to as the famous Azopardi effect. Okay, moving forward, we are done with the lung cancer related questions, and by now you already know the importance of this and you know that this is going to carry a lot of relevance in your future exams also. Okay, moving forward, there were another set of two questions which were related to a virus. So let's read the two questions and then I'll teach you about it. Which of the following part of this virus is used for vaccination? That was question number 1. So what all was given? There was something to do with the epidermis layers and the dermis. So basically something to do with your skin. Could be epidermis mentioned, something to do with skin was there, okay. Or maybe a squamous epithelium is what they wanted to denote. Okay. Other than that, they had given you the structure of the virus. And guys, this is the structure of the human papilloma virus. How did I know? I can see some proteins called L1, L2. Then I can see E2, E4, E6, 7. So basically, these are all things to do with your HPV. And let me tell you, this was not a previous year topic. This was an exact copy-pasted previous year question. Very rarely does that happen in INI-CET, that exactly the same question is put up once again. But yes, this has happened this time. And that's why I said in every sense, this exam was a little different from the others. So yes, this is used for vaccination, is the L1 capsid. L1 capsid part of human papilloma virus is what I use for vaccination. And in the next session, the same picture came and they said, out of these, which are the parts which are used for carcinogenesis? How does this human papilloma virus cause cancer? So remember, it causes cancer by something known as E6 and E7. So what I'm going to do, I'm going to explain to you everything about HPV that can come in the paper. What are the questions that you get in the paper? So I've tried to make one diagram of HPV. You know, these are the bullet points that you have to know for human papilloma virus. So human papilloma virus, number 1 has something called L1. L1 is what? It is the L1 capsid. And did I just teach you? This was a question. L1 capsid is used for the preparation of what? It is used for the preparation of vaccine. So the first question is sorted. Next, I move on to how does it cause cancers? So remember, these E6 and E7 are going to go and inactivate some very important genes in our body. And I think everyone knows that E6 is going to inactivate P53 gene. E7 is going to inactivate the RB gene, and this in the paper has also been a PYQ where they ask you what does E6 inactivate, what does E7 inactivate. Let me ask you one thing. E6 inactivates P53. What is P53? P53 gene, I think everyone knows, is the policeman of our genome. What is RB gene? RB gene is going to be the governor of the genome. So please remember, out of policeman and governor, if I ask you who's a more senior person, governor is more senior than a policeman. So remember, for the junior official, I have used a smaller number. For the senior official, I have used a bigger number. So that is how you will remember that for the policeman it is E6 and for the governor it is E7. Junior person, junior number, senior person, senior number. Because this combo is also asked in the paper. So you know now, if your policeman is inactivated and your governor is inactivated, it is but obvious that the patient is going to land up with a lot of cancers. Your protectors are gone, policeman gone, governor gone. Protectors are gone, this means cancers are going to happen, right? You'll say after that ma'am, what does it show under the microscope? I think everyone knows that human papilloma virus shows you a cell under the microscope known as the koilocyte. Who results in the formation of koilocyte? It is E4 and E5 which are going to result in the formation of a koilocyte. So again, something that you can get in the paper. Right, so having said that, these are the different questions possible which will help you solve HPV questions, and I hope going forward we will realize that these are the only set of questions and they'll be recycled every time, right? Okay, moving on, going on to the next question, which was again quite an easy one, direct repeat from previous year papers. Which of the following is a receptor for EBV, that is Epstein-Barr virus? The correct answer was CD21CR2. That is the correct answer. So CD marker, you guys know, CR stands for complement receptor. You don't need to know the full form as such, just telling you for your knowledge. CD21CR2 is the marker. So what are the questions that I'm going to get for EBV? For Epstein-Barr virus, I'm going to quickly tell you the bullet points. Going forward for the exam, for the NEET exam, what are the questions that I'm going to get? Question number 1, Epstein-Barr virus is going to attack which cell of the body? Epstein-Barr virus attacks B cells of the body. So that is the question that came this time. How does it enter into the B cell? So if it has to enter into the B cell, how is it going to go? It is going to go via a molecule called CD21CR2. That is question number 2 that they will ask. So via CD21CR2, which is the cell that they're going to target? They're going to target the B cells. After they go to the B cells, Epstein-Barr virus produces these 3 things. God has given it 3 superpowers, and these are the 3 things. So it has a 1, 2 and 10. 1 to 10. Basically, EBV enters my body and makes 1 to 10. What is 1 to 10? LMP1, EBNA2 and interleukin 10. This interleukin 10 I have not made. This interleukin 10 EBV has made. So I call it viral interleukin 10. See, usually interleukins I make, right? Host makes, humans make. But here the EBV has got his own raw material. EBV has got his own interleukin 10. So 1 to 10 EBV has made. And that is exactly how it's going to cause all those cancers. But one very important thing I want you to recall, do you all remember from your general path that interleukin 10 is pro-inflammatory or anti-inflammatory? If I go back to your concepts, which is the molecule which has only anti-inflammatory action? So we had learned interleukin 10 has anti-inflammatory action. Instead of learning it like that, I had told you to learn it as anten-inflammatory. Instead of anti-inflammatory, learn it as anten-inflammatory. So you will always remember that 10 is going to be anti-inflammatory. So now imagine the virus has got its own anti-inflammatory marker. Will it let you make any inflammation? Will it let you make any response? No, it's got its own army. It's got its own army of interleukin 10 that I will not let you make any response only. So it is anti-inflammatory. You'll say, fine, once it enters, it has got 1 to 10, it has hijacked my system. What are the things that EBV is going to cause? I think the most important disease that all of you know is infectious mononucleosis, right? Which is given a lot of other names in microbiology. You've read it. It is also known as the kissing disease. It is also referred to as glandular fever, right? So these are the different things that you have. Although I'm not teaching you the entire topic, but yes, a quick review. This microscopically shows you some very important cells called the Downey cells. And the Downey cells are said to have a very famous appearance called the ballerina skirt appearance. The Downey cells have a very famous ballerina skirt appearance. Now comes time for homework number 2. What is the test that is done for infectious mononucleosis? The first test, which is only for academic purpose, Paul Bunnell test. Now you're going to tell me what is the second test which is actually done nowadays. Most commonly what is done, what is the name of that test? So I just wanted to give you 2 homeworks for this particular session, which you're going to type and let me know in the comments below. The first question was for the INI-CET future aspirants who are going to tell me that HRAS mutation is going to happen in which kind of, or which tumor did I tell you for HRAS? So that is something that I had asked you, which I've already answered also in a way. And second, you're going to tell me that what is the most common test that you have for infectious mononucleosis. Okay, moving forward. Acha, this was just the disease in terms of fever. What cancers does it cause? It can cause carcinomas, lymphomas, sarcomas. So carcinomas, especially the FMGE students, guys, this is a question that has been asked in almost every exam or every alternate session. Carcinoma, the most common carcinoma, many students believe it is nasopharyngeal, but no. It is gastric carcinoma, which is the most common. The second most common is going to be nasopharyngeal carcinoma. So remember, most common question has come in the FMG paper, gastric cancer. For lymphomas, it causes Hodgkin's as well as non-Hodgkin's. Under non-Hodgkin's, it can cause the very famous Burkitt's. It can even cause DLBCL. So Hodgkin's, non-Hodgkin's, both are possible, Burkitt's and DLBCL. Sarcoma, usually not many people know. This I'm telling you for the future INI-CET students, and that is the leiomyosarcoma. So that is not much known about EBV, right? So I've told you the entire spectrum of EBV. I have also taught you how it enters the body, how is the 1 to 10 mechanism happening. So that is going to help you in the future questions also. Moving forward, what do you do next? You have to do match the following. When I say match the following, I told you that there were a lot of questions. So this is such an easy way of testing you on 4 one-liners, 4 images given to you in the same paper. Let's first patch our theory. What did we have? Caesary cells. Caesary cells are something that have a cerebriform nucleus. They are seen in mycosis fungoides. Faggot cells are seen in a leukemia, that is AML M3, also known as APML. Popcorn cells were seen in the NLP, the non-classical Hodgkin's lymphoma, and starry sky appearance is seen in Burkitt's lymphoma. So this is a question which will not come as it is in the future exams. This is going to come in the form of an image-based question. So let's quickly see all these 4 pictures that they gave. They gave you a theoretical question, but future will obviously get you IBQs. So first and foremost, if you see in the blood, look at this cell. The cell is having these cerebriform, like the brain, like the brain has sulci and gyri. So when the cell has this cerebriform nucleus, that kind of a cell is a Caesary cell. And let me tell you, a Caesary cell is something seen in a syndrome called the Caesary syndrome. So no one's going to ask you that where do you see the Caesary cell? Obviously, Caesary cell is something that you see in the Caesary syndrome, but they will ask you what is the counterpart of that syndrome. Counterpart is mycosis fungoides. I want you all to quickly recall, what was mycosis fungoides? Obviously, it's sounding something to do with fungal infection. Is it a fungal infection? No, it just looks like a fungal infection. Why? Because it's something to do with the skin. It is a skin or a cutaneous disorder. Please remember, it is a cutaneous T-cell NHL. Actually, it's a cancer. It's a lymphoma. It's a cancer or a lymphoma, and it's going to occur in the skin. Because it occurs in the skin, it looks like a fungal infection. So people started calling it mycosis fungoides. From the skin, if it now goes into the blood, what are you going to now call it? You're going to call it Caesary syndrome. So simple. Till the time it's in the skin, I call it mycosis fungoides. When it's present in the blood, I call it Caesary syndrome. What is the blood sample going to show me? It's going to show me Caesary cells. How do the Caesary cells look like? They have that cerebriform nucleus. That was the first option. The second option given to you was, what are faggot cells? First and foremost, faggot cells are seen in AML M3, also known as APML, right? And please remember, this is how a faggot cell will actually look like. This is the cell, and you will see lots of OR rods. But those OR rods are going to be like this. Those OR rods are crisscrossing each other. So if you see the presence of crisscross OR rods, you know that I'm dealing with means so many. Indirectly, they also ask you which is the leukemia that shows you maximum OR rods. So you'll say, yes, the same faggot cell is going to show me maximum OR rods, the same AML M3. Can you see so many OR rods over here crisscrossing each other? So yes, that is something that is going to be seen in a faggot cell. Moving on, coming to the third one, they asked you, where do you see popcorn cells? Of course, I can see the cell is looking exactly like a popcorn. What exactly is a popcorn cell? It's a type of an RS cell, right? So that means there were 2 questions on RS cells, because I'm going to teach you another one coming forward. So RS cell usually looks like that owl-eye appearance, right? That is what we've always studied. But here the RS cell is looking like a popcorn. So it's something unusual. That is a non-classical Hodgkin's lymphoma. What is the name that you guys study for non-classical Hodgkin's lymphoma? It is nodular lymphocyte predominant Hodgkin's lymphoma. That is why the examiner must have written NLPHL, nodular lymphocyte, or non-classical means the same. And if you remember, popcorn being the tastiest, so this is the Hodgkin's lymphoma which has the best prognosis also. Okay, having said that, moving on to the last one, which was every student's favorite, the famous starry sky appearance that you see in Burkitt's lymphoma. And there's a question that will come after it, starry sky. So I can see the sky, the blue color is obviously the sky. So the sky is made up of what? The lymphoma cells, the tumor cells, the lymphoma cells are the blue color, all that blue color sky that you are seeing. Versus what are these white stars? These white stars are nothing but the macrophages. These are the macrophages, so these are said to be the stars. So the question that comes in the paper is that starry sky appearance that you see in Burkitt's lymphoma, is that something that is the tumor going to be in the stars or the sky? So the fault is in the sky. The fault this time is not in the stars. The fault is in the sky. So what are the tumor cells? The tumor cells are going to be the sky over here. Okay, so that pretty much sorts out everything in this question. But one more thing. There is one more starry sky appearance that you see in pathology, but that is something seen on a different microscope. Can you see this microscope? This is the famous immunofluorescence, the green color immunofluorescence. And again, I call it starry sky for which disease? PSGN. Post-streptococcal glomerulonephritis, the one that is going to come up with cola color urine. The one that will come up with cola color urine. And over here, why do I call it starry sky? Again, stars and sky, shine and dark. Stars will shine, the sky will not. So if I look at this picture, there are some areas which are definitely shining a lot. This is shining a lot. This is shining a lot. It's as, twinkles are happening in between. And there are some areas which are so dull over here. So you'll say, yes, now I can analyze. There's a starry sky appearance seen 2 places. Number 1, starry sky on light microscope is seen in Burkitt's lymphoma. Number 2, starry sky on immunofluorescence is seen in PSGN. Patient will give me a cola color urine history. Okay, that solves the question for us. Now let's move on to 2 questions which were to do with leukemias. We also saw an increase in the leukemia questions. One more thing I want to tell the FMG students is that till a few years ago, HEMAT was not per se very important in the FMG exam. Same for NEET. But now going forward, the number of HEMAT questions in every exam format are increasing. So first, there was a question on a peripheral smear. I think this is a student's favorite. I get this question and I'm so happy about it, because this is a classical case of CLL. And how did you guys identify? Ma'am, we didn't see anything but these smudged out cells. As soon as I'll see the presence of these smudged cells, I know I'm talking about this particular CLL tumor that we have, chronic lymphocytic leukemia. So see, it looks as if this is, smudged. The tumor cell, I've taken a drop of ink and smudged it. So aisa agar, if I say that this was the, the tumor cell, this was a lymphocyte, this was a normal lymphocyte, a round lymphocyte. And over here, what I've done, I've just broken it. Like ink smudge hota hai, same way I've smudged it. So it can take so many different shapes na. It can start looking like a basket. It can start looking like a parachute. Apna imagination. I mean, you can also give it another name. Smudge cell is basically smudged into any shape. Now, for the future INI-CET exam, they will ask you, firstly, smudge cells are non-specific. This is important for NEET and FMG also. Smudge cells are non-specific. Means, are they going to be seen only in CLL? No. They can be seen in infections also. They can be seen in ALL also. So, they're non-specific. Second is, why do they happen? This is only important for the NEET students because it is said that they don't have an important molecule called vimentin. Vimentin seems to be absent in them, and that is the reason that they are having, they break very easily. They're very fragile. Okay, another question that will come is what is the criteria for CLL? So one thing I understood that smudge cells should not come in the criteria. Smudge cells is just an additional finding. I'll see it, okay, but it's only an added, it's a bonus finding. It's not a part of the criteria. What is the 1 plus 2 plus 3 criteria? All 3 criteria that I have to meet. When I say chronic lymphocytic leukemia, I'm going to focus only on the lymphocytes. And that is, first I will take the peripheral blood. On a peripheral simple blood sample you will take of the patient. What is the lymphocyte count going to be? The lymphocyte count has to be more than 5,000 per mm². The lymphocyte count has to be more than 5,000. I take the same patient's bone marrow. The lymphocytes in the bone marrow have to be more than 30%. So basically everywhere it's all about lymphocytes because the leukemia is all about lymphocytes. Cutoffs have to be learned. In the peripheral blood more than 5,000, in the bone marrow more than 30%, and on flow cytometry they will ask you which marker is positive, CD5 or CD23 or CD200. So you will say, ma'am, CLL sab kuch positive. Everything is going to be positive. The criteria only has 5 and 23. Let me tell you, for the criteria, you only need to fulfill 5 and 23. But I'm telling you 200 also because that was also a previous AIIMS exam question, right? So remember, CLL mein sab kuch positive. All CD markers, 5, 23, 200, everything is going to be positive. And all these 3 criteria need to be met. That is when you say it's a case of CLL. Smudge cells is not in the criteria. It's only an added bonus finding. Why is it not in the criteria? Because it's not specific. That is what we studied right now, right? So that was a classical case. So I realized it's all about lymphocyte, lymphocyte, lymphocyte. This means all the cells are going to look the same, only lymphocytes. This means every cell is in the same uniform. I call this convent schoolgirl appearance. Why do we say convent schoolgirl? Because in school everyone is in the same uniform, right? So in CLL everyone is looking the same. Everyone is just lymphocyte, lymphocyte, lymphocyte. Everyone looks the same. So convent schoolgirl appearance. This was the question that they gave you in the paper. Going on to another question which came from leukemias only, and that was this. A patient with a WBC count of 4,50,000, which is huge. WBC counts are between 4,000 to 11,000. Where am I talking in thousands? And my patient has a 4,50,000 count. It's huge. Obviously, it's a leukemia, no doubt about it. But that is a leukemia that is showing you eosinophils, it's showing you basophils, it's showing you neutrophils. And some students also told me that, ma'am, there was something referred to as shift to the right mentioned. Usually we study shift to the left, but there was neutrophilia with shift to the right. So can that also be seen? Pretty much possible. At this count, you're seeing so many cells. See, look at the previous one. In CLL, you were only seeing lymphocyte, lymphocyte, lymphocyte. Here, you're seeing a full party happening. Whenever you see this kind of a garden party appearance, you will say, ma'am, party means everyone has been invited. Or now, uniform is gone. College girl appearance. College girl appearance means everyone is dressed in beautiful different clothes. See, convent school girl was everyone was in the same uniform. Here, everyone is looking different. Eosinophils, basophils, neutrophils, everyone looks different as if dressed up in college or dressed up for a party. And that leukemia is a case of CML. In fact, basophilia is not seen in many leukemias. Basophilia is seen in CML. And for the FMG students, remember basophil likha hai paper mein, so you're going to mark CML. Only for the future INI-CET students, please remember, when you see basophilia in leukemias, there are 2 things that you should be noting. Future INI-CET aspirants, take a note of this. Basophilia in leukemias, number 1 CML and number 2 AML also. Can you tell me which AML can show you basophils? The AML showing you translocation 6-9. AML with translocation 6-9 can show you basophils. Okay, having said that, this was a case of CML, and finally, you also need to know what are the different, the different phases. A quick recap, not teaching you in detail, but CML has 3 phases, which are known as the CAB phases. That is chronic phase, accelerated phase, and blast crisis. Now, when I go on to that, the basic point is, I have to differentiate these on the basis of the blast count. So, if the blast is less than 10%, it is chronic. If it is between 10 to 19%, it is accelerated. And if it is more than 20 or more than 20%, means that has gone into a crisis, and that is known as the blast crisis over here. Okay, after this, so once you've done CAB, chronic accelerated blast, less than 10, 10 to 19 and more than 20. All the other criteria points are coming under this accelerated phase. So the basophil count has to cross 20%, or if the total leukocyte count is very, very high, platelet count is very, very high, or platelet count is very, very low, either ways, platelet count both ways, or if the patient has a massive spleen and you're saying, ma'am, everything is not responsive to treatment. I'm trying to give the drug. Which drug do you give for CML? What is the treatment, guys, that you study in medicine? We give imatinib. Imatinib dete hain for CML. You're giving imatinib, patient is not improving. When I say patient is not improving, that basically means that the patient has under the accelerated phase. Now in the paper, don't be in so much of excitement that ma'am 20% criteria had come. You have to put up and ask them what 20% was asked. Was this 20% related to the blast? So then you called it blast crisis. And if it was 20% which was related to the basophils, then you put it under accelerated phase. One more question which I want to tell the future NEET PG aspirants is that is there, and something for the INI also, is there something which is known as a special stain for basophils and mast cells? You've seen this in your previous year papers. Basophils and mast cells are going to be toluidine blue positive. Basophils and mast cells are tol blue positive. Okay, having said that, moving on to a quick revision. So finally you realized if I'm seeing only lymphocyte, I'm going to call it a convent schoolgirl appearance. If I'm seeing lots of cells like Eos, basos, neutrophils, means everyone is dressed up differently, college girl appearance. And obviously the guys do have that much of a problem that why is it only focusing on the girls, because we also dress up the same way in college and in school, but yeah, that's how it is. Okay, moving on, coming to the next question. There were two questions which were given to you from general patch. So now for those students who believe that the initial chapters are not important and I'm only going to focus on big tumors, it's a reality check for all of us that yes, the initial chapters will also be asked. Actually, I got two questions from the students in the recall. There was a third question also that I got, which I'll discuss with all of you. So please remember, which molecules help in the movement of leukocytes across the endothelial cells? So the answer to this question was PCAM1 or CD31. Basically, they had asked you for a process that is diapedesis. Same way, and so this was movement question, and in the evening session, there was a question was, which of the following helps in adhesion? If you all remember, adhesion was caused by integrins. Adhesion was caused by integrins, and which is the integrin? So this is obviously selectin, this cannot be the case. PCAM is also not there. The only integrin that you have in the question over here, that is VLA1, right? So now you'll say that, ma'am, since these two questions came, let me also quickly study these cellular events of inflammation. I'm not going into too much of detail. I'm giving you a 2-3 minute most important buzzword wala review over here. So when I talk about what are the cellular events of inflammation, you need to know something known as MRAT-COP, right? What is MRAT-COP? Means 7 events of inflammation are there. So the first one, this is a blood vessel, as you can see. This is a blood vessel over here, and I can see these neutrophils over here. But where have the neutrophils come? They've come to the margin. So what is the first thing going to be? The first thing is going to be margination. I'll keep reminding you of that MRAT-COP. Okay, so the first thing is going to be cells coming to the margin. After coming to the margin, what are they going to do? They are going to do rolling, right? They're going to roll. So how do they roll? They are going to roll like this. How are these cells going to roll? They are going to roll by molecules called selectins. And I think everyone knows English Premier League, EPL. These are the 3 selectins that you have. Some students also told me that, ma'am, there was one more question. Now, very few students told me that, so I'm really not sure whether it did come, but I'm sure students can recall something around that definitely came. So they asked me that, okay, ma'am, when we were talking about English Premier League, they asked you which are the selectins which are on the endothelium and are on leukocytes. So something related to their location was asked. Exact recall we could not get from the students, but as I tell you, maybe you will be able to recall that if you give the exam. So remember the selectins. L-selectins, L for L, they are present on the leukocytes. E-selectin, E for E, they are present on the endothelial cells. And P-selectin, this is the question that students told me that, ma'am, they asked, which are the selectins which are present on platelets as well as the endothelial cells. And please remember that the way you pronounce P bolo, so P bolne mein it looks like P-E-E, right? So P for platelets and E for endothelial cells. So please remember L for L leukocyte, E for E endothelial cell, P for P and E, that is platelets and endothelial cell. And students said that this was asked that which is the selectin present on both. So the answer would have been P selectin. Coming back, M for margination, R for rolling. Rolling is because of selectins. After rolling, they come to a stop. And so they'll keep rolling, 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 and they will finally come to a stop, and that stop is adhesion. So margination, rolling, adhesion. And who carries out adhesion? Adhesion is caused by integrins. Now let me tell you one more thing. Integrins are of two types. Beta 1 integrin, beta 2 integrin. Let me draw it out only. Now what I'll do, I'll enlarge this. This much area, I will zoom in. I will zoom in and I will enlarge it. So look at this. This is the neutrophil. This is the blood vessel. How many integrin? Beta 1 integrin has been written over here. Beta 2 integrin has been written over here. Where are they present? Both of them are on the neutrophil. So remember, integrins by definition are going to be present on the white blood cells, neutrophils. Beta 1, see now no, look at the mnemonics. So you'll say, ma'am, what does it bind to? It binds to something called VCAM1, and beta 1 is also known as VLA1, VLA4, lots of numbers. So now what happens is, in the paper we get confused. So see, when you say beta 1, what sound comes? V wala sound aata hai, 1, V wala sound. So all the VV things will come here. If someone asks you what is the other name of beta 1 integrin, you will say, ma'am, it is VLA4. If they ask you what does it bind to, what does beta 1 bind to, it binds to VCAM1. So all the VLA, VCAM will come on this side. And beta 2 integrin has two names. One name is LAFA and MAC. One name is CD11 and 18. So beta 2 integrin has two names, and it binds to what? It binds to ICAM1. So simple, learn one side. I have learned this side. One is V and V. It is also known as VLA. It is also known as, it is going to bind to VCAM. VV11 is how we learn it. Okay, adhesion is done. What do we move on to next? They ask you how the cell is going to come out. So the cell is going to come out known as MRAT. So margination, rolling, adhesion, transmigration. How will it come out? That was your question in the paper, and that is PCAM1 or CD31. That is how it's going to come out of the blood vessel. This is what was asked to you. So MRAT, after coming out, what is it going to do? So again, margination, rolling, adhesion, transmigration. Ab kya bacha? COP. That is chemotaxis. What is chemotaxis? Chemotaxis is moving towards the bacteria. This is the bacteria. The cell is going to move towards it in one direction. That question has been asked many times. It is a unidirectional movement. Okay. While it's going, what is the bacteria going to do? The bacteria is going to coat itself. The bacteria is going to coat itself, and that is known as opsonization. Why has the bacteria coated itself? Because it wants to become very, very tasty. And why is it becoming very tasty? Because finally, you want to eat it up and kill it out. You want to do phagocytosis. So remember, margination, rolling, adhesion, transmigration, chemotaxis, opsonization, and phagocytosis. That is how you are going to learn this thing. Okay, so this solves 3 questions approximately in this paper. Another, back to match the following that came. There are no images out here, but you just have to match the correct cell with the correct location. So first, let's talk about the cells which whenever you get match the following, it's actually a good thing, because it's not that you'll know all the 4 options, but even if you can match 2 or 3, the one that you don't know, you'll be able to rule out and match anyway, right? So first, let's talk about Kupffer cells. I think there's no doubt about the fact that Kupffer cells are going to be in the liver. Kupffer cells are nothing but the foodie. Kupffer are foodie cells. They are macrophages of the liver. Everyone knows that. Okay, where is the parietal cells present? Parietal cells are present in the body and the fundus of the stomach. Body and the fundus of the stomach are going to have parietal cells. Again, something which is basic first year knowledge. Now I'm left with these two, dust cells and Clara cells, and I can see both the options have they have lung related things, right? So if you know the other name of dust cells, what are dust cells known as? Dust cells are also known as alveolar macrophages. They take all the dust. See, all the dust, all the pollution, everything that we inhale, all of that is going to go into our lungs. And when it goes into the lungs, which is the cell that is going to eat it? There's a cell in our lungs known as macrophage. Macrophage is always ready to eat everything, right? So macrophage is going to eat it up, and that is why I call it alveolar macrophage. It's eating the dust, so I call them dust cells. So automatically, where are the Clara cells present? The Clara cells are going to be present in the bronchioles. So both of them are actually lung related, but dust are macrophages, so they are in the alveoli, and Clara is going to be in the bronchiole. So there's no image needed for it. This was a pure first year match the following cell with the location question. Very, very primitive question, very basic question. Something not expected in INI-CET, but yes, as they said, they gave you a reality check that while running after too many big things, don't lose ground, don't lose your basics. Okay, another question that came on the lymphomas. Which of the following markers are positive in Hodgkin's lymphoma? I think everyone knows 15 and 30, the very, very famous 15-30 markers that we have are positive in Hodgkin's lymphoma. So what cell are we talking about? The cell that we have is the Reed-Sternberg cell, right? The Reed-Sternberg cell, which is the classical one, the owl-eye appearance. And what are the markers? There are 3 markers that we have to know. CD15, double of 15 is 30. And PAX5. 15, 30 and PAX5 is what is there. And please remember, out of them, the sensitive one is 30 and the specific one is PAX5. Sensitive is 30 and specific is PAX5. Okay, and let me tell you one more thing for your future exams, not important for FMG but important for the others, that when I'm talking about PAX5 is always to do with B cell development. So whenever they say some PAX5 related problem has come, always think of B cell problem, because is Hodgkin's lymphoma also related to B cells only? Yes. Whenever they mention PAX5, some B cell etiology has to be thought of. So here the answer was typical. Here you had 15, 30. If they would have asked you sensitive, you would have marked 30, and for specific, if would have been there, so PAX5. Okay, moving forward, this was another question, a pretty easy one, not a tough one, but if only that you had to know that there is something called bare lymphocyte disease. This is not something I expect in the FMG exam even going forward. So FMG students can take a skip on this, but yeah, INI-CET and NEET is important. What is bare? So, the first half of the question was only given to confuse you, that absent graft versus host disease or reaction. They actually wanted to tell you what is the problem in bare lymphocyte syndrome. So bare lymphocyte syndrome, guys, is a syndrome. So see, this is an antigen presenting cell and this is a T cell. I think everyone knows that antigen presenting cells have MHC2. I think that is your basic from immunology that you know. Antigen presenting cells have MHC2, and I say that when MHC2 goes missing, so it's what, if, for example, if this is an antigen presenting cell, MHC2 is kind of covering it. This is MHC2 on top of it. I am saying the MHC2 has gone, the covering has gone, it is missing, the cell has become bare. So I call it the bare lymphocyte syndrome. I call it bare lymphocyte syndrome, and that is exactly what they had asked you. Bare lymphocyte syndrome is a deficiency of MHC2. The rest of the story was just given to, confuse you that a tough question from immunology has been asked, but that's not the case. This was a classical MHC2 absent. Okay, moving on to the next question, something which we saw a lot. We saw something to do with numbers and cytokines. Which of the following is not seen with T helper cell 1? The answer to that is interleukin 4. So what we'll do, not seen. So that is seen actually with T helper cell 2. So we'll quickly tell you how many types of T helper cells do we have. T helper cells basically mean that I'm talking about the CD4 T cells, right? T helper 1, 2 and 17. 17 is simple. T helper 17 releases interleukin 17, also 22, but 17 is main. So 17 for 17, simple. T helper 1 is going to release, so remember 1 releases 2 and with 1, 2 you make 12. So T helper cell 1 releases interleukin 2, interleukin 12 and interferon gamma. So remember 1, 2, 12, 1, 2, 12, 1, 2, 12 and interferon gamma. Let me tell you a few points. Remember, interleukin 2 creates a loop with it. That you release me, so you benefit me and I will benefit you. That kind of a symbiotic relationship. That T helper cell 1 releases interleukin 2. Interleukin 2 further helps in the production or the activation of T helper 1. That is one thing. Interferon gamma is very important because G for G. Gamma is going to help you in granuloma formation. Gamma is going to help you in granuloma formation. Guys, which hypersensitivity is granuloma formation? Hypersensitivity type 4, right? So indirectly, if they ask you that which is the T helper cell which is used in type 4 hypersensitivity, you will say, okay, T helper 1 releases what? Interferon gamma. Gamma causes granuloma formation, so TH1. So 1, 2, 12, interferon gamma. What does TH2 release? 4, 5 and 13. I call them the ones that are to do with asthma. If you read the pathogenesis of asthma, you use 4, 5 and 13. Why? Because this is hypersensitivity type 1. So what does 4 do? 4 makes antibodies. 5, fifth alphabet. What is fifth alphabet? E. So what cell is activated? Eosinophil activation is going to occur. And what does interleukin 13 do? Interleukin 13 causes mucus production. So do I see all these things in asthma? Do I see antibody formation? Do I see lots of eosinophils? Do I see asthma mucus production in the cough? Yes, so 4, 5, 13 come from TH2. So coming back, as I said, 4, 5, 13 come from TH2. TH1 releases interleukin 2, interleukin 12 and interferon gamma. So definitely going forward also, this table is important. Okay, moving forward. Another much expected questions, we also gave it to you in the list of the must do questions, and that is what is true about sirtuins. So actually, everything that I saw over here, this must have come as a multiple choice question, right? They must have given you are A, B, C correct, are A, B, C, D correct, that kind of a question must have come in it, right? So as per me, all these things that were written over here, all of these were correct. So let me quickly teach you what is sirtuins. Sirtuins is a protein that God has gifted us. All of us have sirtuins, okay? All of us have sirtuins, and sirtuins are derived from sirt genes. There are a total 7 type of sirt genes. Sirtuins have come from that. So what are sirtuins? They are enzymes. What enzymes? Histone deacetylases. So there are 7 genes. They make an enzyme called histone deacetylases. And what are the benefits of sirtuins? The benefits of sirtuins are A, for anti-aging. They make us look younger. If I increase them, they will make us look younger. Now they are saying they can be used in, they're not documented, but research is going on that they can be used in the treatment of cancers and they can be used in the treatment of diabetes mellitus. How do you think they are used in the treatment of diabetes mellitus? What kind of a drug would you want to use for diabetes? You'll say, ma'am, something that helps with insulin. Something that increases insulin sensitivity. Because the problem with diabetes is what? The problem with diabetes is that the person is insulin resistant, right? You want something that can make it insulin sensitive. So now coming back, true about sirtuins, are they going to increase the insulin sensitivity? Of course, yes. Do they increase longevity, which basically means that are they going to help you in anti-aging? Correct. Are there 7 types of genes and are they histone deacetylases? So as per me, all the statements given over here were true. So there must have been an ABCD option that you had to select from. Well, that wraps up sirtuins, and quick answer from your general path. How should I? Because they are obviously, I can see one very, golden thing over here, that how is it going to help me live longer? So they say that less of calories and more of red wine. Less of calories and more of red wine. So you'll have to eat less, drink more is basically what they are saying. But all of this is under a lot of research. Nothing has been, no quantity, no amount of alcohol or red wine or no amount of food has been documented that this much is going to help you in this. This is all coming across as research, and in the future obviously we'll be knowing. So less food and more of red wine can increase sirtuins for us and help us in living longer. Okay, moving on and going to the next question. There was a question regarding which of the following is true for hemophilia A. I think everyone is aware of the different types of hemophilias that we have. So first and foremost, hemophilia we have, I'll quickly tell you. There is something called hemophilia A, there is something called hemophilia B, hemophilia C, and then there is something called parahemophilia also. Be it whichever kind of hemophilia that I'm dealing with, the end of the day, it's basically a factor problem, coagulation factor. So A looks like 8, A8. So which factor deficiency? 8 factor deficiency. The next number is 9. So B is going to be factor 9 deficiency. C is going to be looking like, I'm going to make an E out of it. This will tell me it is factor 11 deficiency, and para is penta, panch, para, penta, panch. So that is going to be factor 5 deficiency. Repeating, A for 8, B is next number, next alphabet 9, C is 11, P is penta 5, factor 5. They asked you hemophilia A, is it factor 8 deficiency? That is correct. Now let me tell you, A and B are seen as XLR. They are X-linked recessive, and I know for a fact that X-linked recessive is more commonly seen in boys, so this was also correct. Now, on the other hand, hemophilia C is like this, CAR. Hemophilia C is learnt as CAR because it is autosomal recessive. So that is the question that you get. Hemophilia A and B are XLR and C is autosomal recessive. So here A was asked, it is XLR and it is more common in males, it is factor A deficiency. All this was true. The fourth option was mucosal bleeding is commonly seen. Mucosal bleeding, first and foremost, I want to tell you a basic thing when it comes to bleeding. Whenever someone or any patient comes to you with bleeding, there are two problems. You'll say, ma'am, either the problem has happened in his platelets or the problem has happened in his coagulation factors like factor 8, hemophilia and all. So if the patient comes to you with superficial bleeds, like over here mucosa, skin, petechiae, purpura, these kind of superficial bleeds are mentioned, then in those cases I'll always think of platelet. So mucosal bleeding goes more in favor of platelet, not hemophilia. Hemophilia patients will come to you with joint bleeding. And many students did tell me that, ma'am, the question of hemophilia did have a joint pain or a joint swelling kind of a history mentioned, and or some kind of organ bleeding. So basically, whenever the examiner tells you anything to do with deep tissues, you will think of clotting factors, and superficial things are going to be platelet problems. Here a superficial thing was mentioned. So this is not to do with hemophilia. This was false. So either they told you to pick up all the correct statements, or they told you to pick up the incorrect statement, but now you know how the entire question was framed. Okay, having said that, this was another question which came from medicine or general path. Hereditary angioedema is due to the deficiency of. So I think everyone could answer this very, very easily, and that was C1 inhibitor. So C1 esterase inhibitor. So quickly I'll tell you what all do we need to know for HAE. What is HAE? Hereditary angioedema. What is it a deficiency of? It is a deficiency of C1 inhibitor. So I'll give you a quick recap. See, complement system. When I'm talking about the complement system, it is constantly working in the body. Because it is constantly working in the body, that basically means that there needs to be someone to stop. Who is that person who's going to stop it? It is the C1 inhibitor that's going to stop it. Inhibitor that will stop the complement. They don't keep working all the time. But if someone has C1 inhibitor deficiency, means that there is no one to stop the complement. There is constant activation of the complement system. Patient is going to result with edema, swelling episodes, very commonly around the eyes and the lips. So the face and the lips, and obviously you can see the feet, you can also see the genitals. So edema can happen in many places of the body, but remember that when can it come across as a medical emergency? It can come across as a medical emergency whenever there is edema of the larynx. That is going to result in respiratory distress, right? That is going to result in respiratory distress, which means the patient will be gasping for air, and that is when it will come as a medical M in your casualty, in your emergency room. So yeah, that was the question over here. I think everyone got it right. It is a case of C1 inhibitor. What are the other options, guys? When does CD 55, 59 would have been given? That would have been a case of PNH. C2 per se is not many diseases, but the most common complement deficiency that you see in humans. The most common complement deficiency in humans is C2. And MAC deficiency. MAC deficiency you will always get in microbiology, something to do with Neisseria infections. Neisseria meningitidis, matlab meningococcal basically. Those kind of infections. So MAC will be very commonly associated with meningococcal infections. So I think that solves this question as well for all of us. And yes, that is pretty much simple. And other easy questions, I've kept all the easy ones for the end. There's another question that was given by some students. Somehow the others were not able to recall it. So probably it was only in one of the sessions. That was senile atrophy. Senile atrophy is due to what? It is a decrease in the blood supply. So I just want to tell you that senile atrophy is something that you see in association with Alzheimer's disease. Senile atrophy is something that you see in the brain, something in old age, and all of that happens whenever there is a decrease in the blood supply. So see, Atrophy, shrinkage, that can happen if the nerves are cut, if the blood is cut, if the nutrition is not there, if the working is not there. Atrophy can happen because of any of these. But remember that senile atrophy, the one that you see in old age and the one that you see in Alzheimer's, that is mainly because of a decrease in the blood supply. Having said that, let's move on to the next question, something that came from Gynae as well as Path. Carcinogen associated with clear cell carcinoma of the female genital tract. So many times we've studied this. Clear cell carcinoma of anywhere in the female genital tract, be it the vulva or the vagina. And this photo was also a formality. If you zoom in, you can see all the cells are all khali, they are all clear, they are empty. So yes, this was a clear cell carcinoma and the drug is actually DES. What is DES? It is diethylstilbestrol. It is diethylstilbestrol. It was actually an estrogen preparation. It's not given now. This drug is banned. Why was it given? It was given to pregnant mothers. Once upon a time, it used to be given to pregnant females so that they could have a normal vaginal delivery. Because hormone balance hota tha. So, by giving this drug, they used to have a hormone balance and it used to result in a normal vaginal delivery. So, everyone was happy. But later on, they found that if this female gave birth to a daughter, that daughter was landing up with these cancers. Daughter was landing up with clear cell carcinoma. So, what was this story very famously known as? This was known as the story of the DES daughters. This was known as the story of the DES daughters. The DES was given to the mother, pregnant mother, and the daughter was having cancers, and that is why this drug was banned. But yeah, the question came, DES is something associated with clear cell carcinoma. Okay, moving on to the next question. There is a child over here whom we have, and there's a child with hemolytic facies. As I say hemolytic facies, that one thing that definitely comes to my mind is frontal bossing. Something certainly coming to my mind is frontal bossing. So, something that could be a case of thalassemia. Okay. Next, they are saying the person also has enlargement of spleen and history of recurrent blood transfusion. Must be a case of thalassemia major. That is exactly when recurrent blood transfusions are needed, right? So, what are the investigations? Obviously, for any kind of anemia, peripheral smear I will definitely be doing, for obvious reasons. Other than that, what is the gold standard for investigation? What is the investigation that you do nowadays for all the hemoglobinopathies? We do HPLC, right? Other options were bone marrow, PT-APTT. See, PT-APTT as the first line investigation I'll never think of, because that I'll go for a clotting factor problem. BM, bone marrow, I would do for leukemia, lymphomas, for some anemias, but as a first line, when I can get my diagnosis of thalassemia major from peripheral smear and HPLC, obviously that will be the primary thing that I will go in for. So honestly, I would have gone for an AB, that is PS and HPLC, because that will anyway be helping me in the diagnosis of thal major, bone marrow, if needed, and PT-APTT obviously in the next line of investigations if needed at all. So primarily PS and HPLC for hemoglobinopathies. Okay, moving on to the next question. So I could not gather a lot of options from the students, because I think once you know a question, you don't read too many options in the exam. But they asked you that what was the principle of this instrument shown. So I think down in 2022, why are they asking something that was done 20 years ago? But yes, MCQ exams are very unpredictable and you never know when an ancient primitive question pops up in front of you. So what is this particular instrument? This is basically Sahley's hemoglobinometer. This is Sahley's hemoglobinometer. So the name only tells me that this is going to be used for hemoglobin estimation. And what do I do in this? I take blood and I add N/10 HCl. I take blood and I add N/10 HCl to make what compound? We make acid hematine. I think as what the students told me that ma'am, this is what was asked. So you're going to put a tube over here. In that tube, what are you going to do? You're going to add some blood. To that blood, you're going to add N/10 HCl. And a brown color compound will form which will be acid hematine. After that, you keep adding and diluting it so that you can compare it with the comparator. There's a comparator in it. This is the comparator box. So you can compare it with the shade. You have to match it with the brown color shade, and that is going to tell you the hemoglobin value. So obviously no one does it nowadays. We have automated machines to do it. But yes, Sahley's hemoglobinometer is based on the principle of acid hematine. Okay, moving on to the next question. Okay, so you have someone, again, there were two questions, one different in the morning and the evening session, something to do with anemias again. So you have a 10-year-old male patient. Let me look at these. Low MCV, low MCH, hemoglobin is also low. WBC is almost fine. Platelet count is increased. What is the normal platelet count? 1.5 to 4 lakhs. Upper limit you can even stretch to 4.5 lakhs, but that's it. 5 lakhs is not normal. 5 lakhs is increased. So MCV is low and MCH is low. I know for a fact that it is microcytic hypochromic. Microcytic hypochromic. In that, I also realized that hemoglobin is also definitely low. So it is microcytic hypochromic anemia. Then I look out for serum ferritin, storage form of iron. What is serum ferritin? Serum ferritin is said to be the storage form of iron, and I realized the storage form of iron is also low. So this is what? This is a classical case of iron deficiency anemia, because if you look carefully, majority, what are microcytic hypochromic anemias? Everyone remembers the mnemonic SITA. S for sideroblastic. So pehla to sickle cell anemia cannot fit into it. Iron deficiency can, thalassemia can, and anemia of chronic disease also can, right? But please remember that IDA I selected because the iron, the storage form of iron over here was low. Okay. Having said that, one more thing I want to tell you is that in most cases, I'm not saying all, but in most cases of iron deficiency anemia, as a reaction, the platelet count tends to go up. I'm telling you, this was given from a very practical pathologist point of view, that most of the cases of IDA that we see thrombocytosis. We see the platelet count is on the higher side. It's said to be a reactionary change. So yeah, that was also mentioned over here. The next session got a similar question, but I'll show you the next question first. Look at this. What did you have? You had the same 10-year-old boy. You had a hemoglobin which was again low, and this time they gave you values. MCV was low, MCH was low. So please remember, you have to know the normal values for MCV, MCH and MCHC. The normal values need to be known. So remember, MCV is 80 to 100 femtoliters. MCH and MCHC, you start from 27, you end at 37. Then you break in between. So 27 to 32 picogram is MCH. And 33 to 37 gram per deciliter is MCHC. So basically you have MCV sorted 80 to 100. MCH and MCHC start from 27, end at 37, put a break in between. So look at MCV 56. 56 means it's definitely low. Look at MCH 22. So that is definitely low. I am again dealing with the case of microcytic hypochromic and anemia definitely, because look at the hemoglobin. Hemoglobin is 7.6. Then I decided, okay, look at the total leukocyte count. Everything almost looks 7,600 normal. Little lymphocytes are more. But on the other hand, I am more interested in the anemia part, right? I look at the serum ferritin. In this question, they gave you the normal value. Normal value they gave as 130 to 140. Some students said that, ma'am, the ferritin was just marginally raised. It was either a 150 or a 160, but it was not a very high ferritin. Now, when I say microcytic hypochromic anemia, with that kind of a history, where I'm saying that the ferritin is just marginally raised, ferritin can be raised in two situations. See, iron deficiency mein to ferritin had to be low. We just studied, right? So students who got that previous question, you were lucky. Right? Sickle cell anemia doesn't fit into this situation because it's not microcytic. Now I'm left with thalassemia and anemia of chronic disease. In both of them, ferritin can be increased. In both of them, ferritin can be increased. So what should I select, ma'am? See, if this was the question, I don't know if I've been able to recall this from the students correctly, but if this was the question, I would have definitely gone in for a case of thalassemia. Why do I say that, guys? Because in anemia of chronic disease, they say that although we study it under SITA mnemonic of microhypo, they say normo is more common than microhypo. So going by that concept, I would have gone for, because over here there's no normo concept. I can see this is a clear-cut microhypoanemia. So going by that, I would have gone for thalassemia. Although for thalassemia, if they would have given me the RBC count or the Menzer index, I would have been all the more certain. But yes, with whatever information I've got, thalassemia seems to be the best answer. Moving on to the next question. This was a question which was much expected, and it definitely came. Now in this question, I would tell the FMG students to take a skip of this question because it's never going to be asked for you guys. But yeah, for the NEET and the INI students future may also, this is going to be an important. This has come in NEET also earlier and now in INI as well. So what was this graph given? This graph was basically a graph of thromboelastography. A graph of thromboelastography. And what do I see over here? I can see something called R time. So it's simple blood test. It's a simple blood test. What do you want to find out? What do you want to find out in the blood test? Is the patient having any bleeding defect? Means platelet problem, coagulation problem, those kind of problems. That is why you said thrombo, na? It's thromboelastograph. Okay, so R time, K time, there is some alpha angle, there is MA and there is L/30. So, they asked you maximum amplitude, MA, maximum amplitude is to do with which of the following? So, maximum amplitude is to do with platelets. What am I going to do? I'm going to quickly give you an overview. देखो ये वाला graph है and these are the 5 things that we have to study. So quickly one by one we'll find out, okay, what are their normal values and what do they signify? I mean, if I don't get them within the normal range, तो problem क्या है? What is going to be the problem? So let's zoom into one by one. Look at the first line. The first line over here is said to be the R time. What do I mean by the R time? The R time means the reaction time and that is 4 to 8 minutes. What reaction are you trying to find out? From the starting till the time the clot is formed. From the starting till the clot forms, that is what's a reaction from the blood to the clot. That is 4 to 8 minutes. So obviously clot will depend on what? Clot will depend on clotting factors. After you've made the blood clot, next you want to analyze the K time, which is very less. If you see, the K time is a very chota sa line, a very small line over here. It's a very small timing over here. That is the K time. And they say K time is just 1 to 4 minutes. So what is the K time? K time is going to tell me the strength. Clot to ban gaya, clot has formed. In the previous one you saw that clot is formed. Now you want that clot to be very strong. So K time is going to make that clot at a fixed strength. To reach a certain strength, it's going to take 1 to 4 minutes. And who is going to give it the strength? Always remember, I have learned fibrinogen is a cement. Whenever you want to fix something, whenever you want to make something stronger, fibrinogen is going to come and do that. So K time is, so there's a very funny way of learning it, that R time was to do with reaction. So I first understood the reaction of the blood clot. After that, I wanted to make it kadak. Okay, if I wanted to make it kadak, so K time. I wanted to make it very strong. So I did K time, 1 to 4 minutes. Then what do you see next? You'll say, ma'am, there's an angle going up. There's an angle going up. So that angle I had to measure. That is known as the alpha angle. So angle is to do with dynamics. I'm not talking about the time. I'm now gone into the angle phase. When I'm wanting something to go up, that is the angle phase, means I'm talking about the speed. Kitna angle? 4774. 47 to ulta 74. So 47 to 74 degrees is the normal angle and that tells me the speed at which this accumulation is happening. Finally, guys, look at this. The graph has reached its maximum strength. The maximum amplitude, maximum point of the graph has been reached. So that is maximum amplitude. You will say, ma'am, this is the max strength that a clot can have. After this, the clot will start breaking. This is the maximum strength and this depends on both the platelets and the clotting factors. But in this question, they asked you, what is it maximally dependent on? Maximally, it's the platelets. So remember, for maximum amplitude, it's the platelets which are going to do all the work. And that is the question that came in your paper. Because after this, what is L/30? L/30 means lysis after 30 minutes. After 30 minutes, up till 8% of the blood clot will break, right? So now you can see the graph has started going down. So if I just quickly analyze this graph once again, guys, what do I notice over here? I see the first one was what? The first one was R time, reaction time for the clot to form. Then a chota sa K time for it to become kadak or strengthen. Then it had alpha angle 4774 to know the speed. Then I came to MA, that is maximum amplitude, which was to know the maximum strength. And then it started breaking, that is L/30, that is going to be up to 8%. So here MA was asked. MA I would have marked it as platelets. There's one more question which all of you, if you could recall, I would really want that you can tell me in the comments below. There was a question which students said that, ma'am, was something to do with stains and match the following, which one of the sessions had. I've not been able to get all the options, but yeah, whatever options I got from students seemed very simple. There was a question of stains and structures. So I think students said, ma'am, Congo red was given. So I'm sure that must have been amyloid. Iron stain was asked, which I'm sure everyone had been able to answer, that is Prussian blue. And pass can be positive in a lot of things. So students told me that, ma'am, basement membrane was there, but the exact question we have still not been able to gather. So yes, that is something that you can definitely help us with in the comments below in case you saw that in your particular paper. Okay, having said that, moving on to the next one, there was also a question which the students had a problem with, which was this. It's actually a microbio question, but a lot of students wrote to us versus asking about Ehrlichia versus anaplasma. So first and foremost, there was a morula that was mentioned. Now students were a little confused that was it a case of Ehrlichia or was it a case of anaplasma. So let me tell you, if by chance they had given you a case of monocyte, it was Ehrlichia. If they would have given you a neutrophil or neutrophil ka precursor, that is band form, then it was anaplasma. So I think most of the students told me later that, ma'am, this was the picture, it was a neutrophil or a band form. So remember, neutrophil tha ya band form tha, so then the accumulation of that morula was anaplasma. And if it was monocyte, then monocyte is going to be Ehrlichia. So this is how you had to pick up this question. This is just something I've discussed with you because a lot of students were having a difficulty in this question. So yes, you can now decide what came in your session and you can mark as per that. With that, guys, we definitely wrap up this particular session. We are done with the discussion that we had to do for the pathology questions. I hope you guys have been able to, benefit from the same. And the purpose of this session, that I'm repeating again, was nothing to do with only knowing the question and the answer. It was definitely to do with going forward. What is the road ahead? What are you supposed to study? How are you supposed to study? How are you supposed to finish these questions off? And I think we managed to do that, right? So yes, thank you for joining in. Thank you for listening so patiently. It's been a lengthy session, but I hope you've taken some pearls of wisdom back home. Study well, guys. We'll be meeting in the future also for having a lot of discussions over your upcoming exams. So study well. All the very best.